This is a lady in her late 50s with a uveitic cataract. She has been treated earlier for tuberculosis. In fact, she has been treated as a tuberculosis uveitis, and she underwent a full course of a anti-tuberculosis treatment. And 5 years down the line, she has presented with this dense cataract. Vision is only 6 by 60, and the eye has been more or less quiet for more than a couple of years. So we have taken her up for surgery, knowing fully well there will be a lot of difficulties. So initially I put in my incision, and I already know that this has a dense fibrotic membrane. So I have gone ahead and pre-placed my incisions for the iris hooks. I do stain the capsule, although it's more of a membrane there, and I am trying to separate these Synechae and this membrane with my Sinskey hooks. So I've separated out the Synechae, and now usually I pull off this fibrotic membrane. I try to tear it tangentially, but this seems to be pretty dense. So whatever I do, you can see it is putting a lot of strain on the root of the iris. So I really try hard to get a hold of this membrane and to tear it off, but it's just not giving way. And all the time I am very carefully looking at the root of the iris. You can already see some bleeding spots, and this is a cause for worry. See, even though I try to pick up the membrane with the Sinskey and then hold on to the membrane, I am not able to tear it at all. I have tried several attempts, and I think it is getting a little dangerous. I don't want iridodialysis. So I even try to hold on to the iris with my Sinskey hook and pull off, but absolutely just didn't give way. So finally I gave up, and I decided just put in the iris hooks. And iris hooks are a good way to handle a pupil with a fibrotic membrane. You cannot do it with any other device. So you can't do it as efficiently as iris hooks with other devices. So here I am putting the iris hooks, and you can see it is a pretty dense cataract. She happens to be a diabetic as well, so I expect a leathery cataract. I put one extra iris hook through the main incision to give me more space. I was hoping to do a largish, at least a 5.5 mm rhexis, but it's very, I'm really not sure. I'm not able to visualize properly. It has not stained that well. I can't see the capsule, and rather than go with my Uthrata, I decide to continue with my usual method, that is with the bend 26 gauge needle. Down there, little difficult to visualize, so I just push off the flap, and then I'm able to see. There it is. Very carefully guide the rhexis to completion. Once that's been done, I go ahead with my hydrodissection. there was one complete fluid wave there. I decompress. Just pressurize the chamber a bit, put in some HPMC. I've taken out the iris hook from the main incision, and now it's time to Phaco. And this was not such an easy cataract to Phaco. I think the main problem was it's a bit on the leathery side, and the hard part of the nucleus is hardly confined to a few millimeters. So the moment I cross those millimeters, I am into the soft epinucleus, and there is not much of a hole there. So and that's what happened. I realized that in the first chop. So I go little behind. I'm finding it difficult to rotate it also. Do get a hold and manage to get a chop. Once you get that chop, unfortunately this piece has come out, but anyway, once you get the chop, I find it much easier to rotate. And you can see there's just that small bit of central core nucleus that is with enough rigidity to give you a hold. The rest is just epinucleus. So I'm very carefully chopping my way through. The vision is not that great in the other eye as well, which will need surgery also at a later date. So I have to be very careful in this case. However, all seems to be going well. Remains to be seen once I remove the pieces. Looks like some are still. Yeah, that's it. The segment has come through. Once you get one segment, it's very easy to get the rest of it out. And as I said, very small central core nucleus. Most of it is this epinucleus. And I have to be very careful not to bring the PC into my Phaco tip. Such a thick epinucleus will take such a long time if you try to do it with your IA probe. So it has to be done with the Phaco probe. However, the superior part is very stubborn, so I put in some HPMC, come out, put in some HPMC and rotate that part to a more accessible area. And in these cases, I think this is what is required, a lot of patience. You try to hurry anything here and you're going to land up with a complication. And there, that's done. And look at that capsule. It is just trampling all over the place. I have to be very careful removing this cortex. The rexus is a bit small. And all this is unedited, just to show you how I went about doing this case. I have to switch between my parameters often. When I go into the furnaces, I'm going at very low vacuum and outflow, just engaging the cortex, bringing it to the center, and then increasing my parameters for aspiration. Because if you just watch how that capsule is almost dancing, I can easily get that into my port if I'm not careful. And the capsule doesn't look too strong either. So it's in these cases that you have to be extremely careful. Don't go with very high parameters into the furnaces. You will definitely catch the PC and bring it out. So I'm almost going in my polishing mode to the pharynxes, just engage the cortex, bring it out, and then once I'm in a safer zone, I go back to my aspiration mode, aspiration parameters, sorry, and aspirate that cortex. And you have to have a lot of patience for this. So I just switch hands to get to the other side and see how much cortex is coming out. You cannot leave cortex in these cases. You don't want any post-op inflammation in these cases. See, it's not aspirating because I haven't picked up the parameters. Once I increase, it will aspirate. And this is what I am trying to show you, how patient you have to be to handle a case like this. Just bring it out, then increase the parameters and aspirate it. Again, I go down to lower parameters, go to the pharynx, engage, strip it, bring it to the center where it is much safer, increase the parameters and aspirate it. And this, you can see the vitreous debris also. And there is a lot of muck on the posterior capsule. I'm not going to attempt to take it out. I don't want to polish this because I am pretty sure any attempt at polishing will definitely rupture the capsule. I do try to push it with my visco cannula, not helping. Capsule is too loose, so I just put in my visco. The central area is pretty clear, I don't have to worry. And I'm injecting my single piece PMMA tipped foldable IOL into the bag, directly into the bag. I just tap the lens to make sure it's in the bag. I release all the iris hooks, remove them, and now I take my dialer and pull in this. See, this is all these uveitic cataracts will have a very floppy iris. So you have to, it's very easy for this iris to go and get incarcerated into one of your paracenteses. So I'm just releasing all those, and you can see how floppy that iris is. Just any slight aspiration and it just rushes into the port. So I'm just holding that back and trying to aspirate all the HPMC out. I can't leave any HPMC either. And once that's done, I inject some triamsin alone into the anterior chamber and wash it off after a few seconds. This is in the hope that it will control any post-op inflammation that may ensue. Because I did handle the iris with the iris hooks. So, and also the fibrotic membrane that I tried to tear. So all this is going to set in some inflammatory reaction, definitely. Once that's done, I hydrate the wound and conclude the surgery. Thank you so much for watching.